Hi, this is Nick Morris for the NCS podcast, and this is our live at annual series where we are taking hopefully the best and brightest from the sessions at the annual meeting. And with me after the clinical trial session, I have Dr. David Greer. Dr. Greer, thanks for joining us.
Thanks for having me, Nick.
And Dr. Greer just released for the first time the results of the INTREPID study. This is a study that we at the University of Maryland enrolled in. And maybe you could just give us a quick summary of the study and why you did it and what you found.
Sure. So thanks. So we looked at patients with acute vascular brain injury, and that means ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage. And the question was, we knew that fever occurred in these patients. We knew that fever was associated with worse outcome. What we didn't know was preventing fever. Does that actually benefit people or not? And so that was the premise of the study. Could we use fever prevention versus standard care to impact outcomes?
Great. And what did you find?
Well, we found that we, A, could control temperature, which is a really important question. And B, we looked at secondary outcomes also to see, did it actually make a difference? So the first question was, were we able to control in this population, an ICU population, even keeping people at normothermia? And the answer was there was a statistical difference between the patients who were kept normothermic, or the fever prevention arm, and the standard of care arm. So that was great to show that we could at least do that. The more important question is, did it impact outcomes? And we looked at the 90-day modified Rankin scale score of 0 to 3 as the proof of benefit, and we did not find that there was a benefit by preventing the fever up front. We looked at a number of secondary outcomes, including the Glasgow outcome scale extended, the Barthel index, MoCA scores, and across the board, we didn't find any benefit for the functional outcomes. Now, interestingly, there were a bunch of patients, about 30% in the standard of care arm, who never got a fever. So maybe that diluted the trial to a certain degree. We're not sure. The shivering control in the fever prevention arm was challenging. A lot of centers struggled with that. So could that have worked against that arm? It's unclear. We did not find that there was an increase in mortality or any lengthening of ICU stay or overall hospital stay. So those things were all good, and no difference in the significant adverse events either, including pneumonia, sepsis, mortality. They were all equal between the groups.
Yeah. So I think as someone who participated in the study, we all would have hoped to have seen a greater effect that would have shown benefit to patients of treating fever, which is something we all were doing very aggressively for a long time. What's been your clinical takeaway? What are you doing in your practice with fever control, and has that changed based on the results of the study?
Yeah, I think we're kind of back to the drawing board a little bit with that. So I tend to jump on fever pretty aggressively still. I still, in my heart of hearts, think that it's bad, or at least it's associated with bad. And so I don't let people be febrile for very long. But am I convinced that it works? No. Am I willing to let patients be febrile for a longer period of time to find out? No, not at the present time. I'm still treating people pretty aggressively. I don't put them immediately on the Arctic Sun or another device to do fever prevention up front, but I'm still treating fever pretty aggressively.
Okay. And where do we need to go next in this science? Is it about different methods of controlling fever? Is it understanding the basic molecular underpinnings of what's going on here? Where do we need to go in order to better understand the relationship between fever and poor outcomes, and whether this is purely association or there's some causation?
Yeah, I think that the central question is, who gets a fever and why do they get a fever? And if we can figure out, and I think we can from our data, what are the phenotypes of the patients? Are they younger patients, older patients? Is it people with blood in the head or not blood in the head? These are really the central questions. I will admit, we didn't do a great job with the shiver control early in the study. We got better and better at it over time, but as we were adding on more sites, every site had to learn how to jump on shivering better. So could we do better, especially in the early going, to treat the shivering and keep patients comfortable and keep them on the therapy for longer or more comfortably? I think that's a central question also. And then, thinking about what are the right severities of patients. Are maybe the patients that should be in this are ones who are requiring intubation and can get an esophageal thermistor instead, and they're still salvageable, but they're more severe strokes, rather than the person with a subarachnoid hemorrhage who's a Hunt test 1, but has a lot of blood in their head, but they're going to sail through perhaps with no problem, but they may not tolerate the therapy very well at all. These are all the remaining questions that we need to dissect the data to figure out.
Great. Well, lots to be done, but thank you, Dr. Greer, for a wonderful presentation. And I think all will learn a lot from this study. And congratulations, not just to you, but for BD to pulling this off and getting all of our centers to, as you said, go through it was a pretty difficult protocol, but we did it. And I think it shows what we can do in neurocritical care when we all work together. So congrats again.
Great. Thank you, Nick.